Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. Warm welcome to all the respected dignitaries and faculty who are here for today's event. Today's program is themed around key issues, obstetrics and gynecology. We have three eminent stalwarts as chairpersons. We have three leading lights all over the country who are going to be speaking three very important issues that all of us face in day-to-day practice. But before we begin with the scientific proceedings, I would like to express my gratitude to our AMOG's president, Dr. Nandita Palchetkar. Madam is the current president of AMOG's, the immediate past president of FOXY, past president of Mumbai Society and IIGE as well. We thank her for her support, her guidance, and all her blessings in our academic endeavor. Next slide, please. I would also like to express my gratitude to Dr. Arun Nayak, who is the secretary of AMOG's. Sir has been the president of the Mumbai Society in the past. He's a frontline COVID warrior, and he's somebody we all look up to for support and guidance whenever we are organizing academic. Thank you, sir, for your blessings always. Next slide, please. At this juncture, I'd also like to express my gratitude to the ICOG chairperson, Dr. Mandakini Meg, the secretary of ICOG, Dr. Parag Biniwale, for granting us the ICOG credit point for today's event. Thank you for granting us ICOG credit points for all the events so far. You had a fantastic tenure as as chairperson and secretary respectively. And tomorrow is actually the handover ceremony in the Foxy office when the new ICOG chairperson and secretary take over. Thank you so much for your support and blessings throughout the past year. Next slide, please. We have three eminent stalwarts who are going to be chairpersons for today's event. The first of these is Dr. Rajendra Singh Pardeshi, sir. Sir is the current vice president of Fox. He was vice president of Foxy when Dr. Nandita Palchetkar was the president of Foxy. He's somebody we all look up to, an eminent academician, and he's won several best paper prizes at AICOG conferences, invited faculty at innumerable national as well as international events, and he holds the unique distinction of winning so many best paper awards at AICOGs, which is something which can never probably be equaled in the modern era. Thank you so much, sir, for always being here for us. Next slide, please. I'd also like to express my gratitude to my dear friend, Dr. Amir Purandare, who's served AMOGs in several different positions, including the zonal coordinator, the secretary, and the state coordinator, which he is currently. Recently, he's been elected the second vice president of AMOGs starting next term. And we thank Dr. Amir Purandare for being there with us today. He's busy in the Foxy office with a meeting and he will join us as and when he becomes free. Next slide, please. We are privileged to have with us Dr. Sagar Kataria. Sir is the zonal coordinator for Zone 2 of AMOGs. He's been the organizing chairperson for the AMOGs annual conference in 2019, which was held in Mahabaleshwar. The past president and secretary of the Satara OBGYN Society, a distinguished postgraduate teacher from Satara, and he's been serving that population for 25 years. Wouldn't see it, we wouldn't think that way when you look at him because he looks very young. He keeps himself fit with a lot of extracurricular activities, including badminton, running, and cycling, and sometimes even during our AMOGs meetings, you can see sir is pacing up and down. He's walking. He doesn't like to sit in one place for too long. Thank you so much, Dr. Kataria, sir, for being with us. And I hand over to the chairpersons to introduce the three speakers of today. In order, we have Dr. Prerna Keshan, who's the Yuva coordinator of Foxy. We have Dr. Varsha Baste, who is the chairperson for the International Academic Exchange Committee of Foxy. And finally, we have my dear friend Dr. Saurabh Dani, who's the vice president of ISPAT and a very distinguished academician from the western suburbs of Mumbai. Over to the chairpersons, take the proceedings further. I would request Dr. Pardeshi sir to introduce our first speaker of the day, Dr. Prerna Keshan.
Hello, good afternoon, everybody. Thank you, Dr. Pratik Tambe and AMOGs for inviting me for this event. Pratik Tambe is our ever energetic, active chairperson of Endocrinology Committee, and all the stalwarts, Dr. Varsha Baste, chairperson IAC, Sagar Kataria, Dani, Prerna Keshan, and all. So I would like to invite Dr. Prerna Keshan. She is consultant at Horizon Maternity and Fertility Clinic, Tinsukia, Assam. Just I met her in East Zone Yuva Foxy. Prerna Keshan is very active, and she was calling me at that time, sir, this your session is at this, sir, your session is at it. Biodata and all that. She's very active. I experienced in East Zone Yuva Foxy. She has faculty at various zonal and national and international conferences, publication in various journal newsletters and chapters in numerous books. As I told you, she is East Zone leader, ITPC Foxy, chairperson, IMA Mission Pink held Assam, state coordinator for IMA Assam, founder member, INSAG life member ISAR, ISOPAB IMS, patron member PCOS Society, conferred upon the prestigious FICUG awarded Wonder Foxian in 2019 in our tenure only. She is recipient of Woman of the Year of Northeast in Health 2019, recipient of IMA President's Award for Care of Girl, Child and Women Empowerment in 2021, and special interest in high risk obstetrics USG mass scale awareness campaign for adolescent health and maternal mortality. I think she is the right person to address us on preconception counseling. Over to Dr. Prerna.
Thank you, sir. Thank you for the warm introduction. And I extend my heartfelt gratitude to Honorable Dr. Pratik Tambe, sir, for giving me this opportunity to share this forum. And my heartfelt regards to Nandita Palsetkar ma'am, Arun Nayak sir, and our very beloved chairperson, Dr. Rajendra Pardesi sir, for sharing this session for us. I would like to share my screen. I have been interested with this topic of preconception counseling. Is my screen visible?
Yes, ma'am, please go ahead.
Yes, I've been interested with this topic of preconception counseling, wherein this is something which I'm very passionate about. Something which is meeting with healthcare personnel way before attempting to become pregnant. And it includes a preconceptional risk assessment as well as modification of existing risk factors and a set of interventions that aim to identify and modify the biomedical, behavioral, social risk to the woman's health and pregnancy outcome through prevention and management. I would like to really emphasize on this that come what may, in my clinical practice, I take the opportunity of counseling a female preconceptionally from the time she is entering into my chamber, come what may, she is coming for any ailment. She might be coming from irregular bleeding PV, she might be coming for a PCO problem, she might be coming for a recent miscarriage. But I take this opportunity with the back of my mind that, okay, I have to counsel her preconceptually because before she becomes pregnant, I want to make her body fit. As obstetrician, we need to establish the facts and the myths that are revolving around preconception counseling. Apart from the diagnosis and treatment, we are supposed to provide primary preventive care. As from the Esther years, it has been said that prevention is better than cure. But then with preconception counseling, we are actually emphasizing on this primary preventive care rather than going ahead with the treatment and the diagnosis part. The benefits of deliberately preparing for pregnancy relate to the important and critical period of organogenesis, which occurs between the days 17 and days 56 post-fertilization. And this is the traditional early prenatal visit is too late to affect reproductive outcomes associated with abnormal organogenesis. If a patient comes to us at 5 weeks, this period of organogenesis that starts between 17 days of fertilization goes off. And so we are not able to prevent all those neural tube defects and all those things that can be preventable if she would have met us between this day 17 to day 56 in the earlier part of the conception. So why are we actually discussing preconception care? Because of the rampant growth of metabolic syndrome in the country, we Indians, we are the diabetic and the hypertensive capital of the entire globe. And rather than now, we are even increasing on PCO and hypothyroidism. So with this combination of central obesity, type 2 diabetes, hypertension, and dyslipidemia, it makes women contemplating pregnancy more vulnerable to perinatal complication. And this is where the PCC importance is very much pertinent. If the couples fail to seek help preceding pregnancy. What is our duty then? Like what I personally do in my clinical practice is that when a patient comes to me, when a mother, to-be mother comes to me at 7 weeks or 5 weeks of gestation, and she had never done a preconception counseling, and we do not know what is the viability of the embryo like, then I take it a point in this era of medical legal issues. I take it a point to just mention one line in her prescription that takes only hardly 1 or 2 seconds extra, that okay, she has missed on a preconception counseling and she has straight away become pregnant. This was an accidental pregnancy or an unplanned pregnancy. She was definitely in the reproductive age group, but she has never planned a pregnancy, but she's happy she is pregnant, but then she has never evaluated her body prior to becoming pregnant. So it's a duty to consider each visit of a woman of reproductive age as an opportunity for counseling and encouraging preventive health care, because the baby inside will ask you, mommy, did you know that I'm going to become this? Mommy, did you know that I'm going to be viable? So this is one important question that all females need to answer to their baby in the womb, that okay, baby, I know that you're going to be well. I know that you are going to be fine. So this is where the importance of preconception counseling lies. If we talk about the windows of opportunity to do preconception counseling for clinicians, we can see if a patient is coming to us who is newlywed, this couple is coming to us seeking contraception, but then at the back of our mind, we can say them, okay, you have right now come for contraception, but when you are planning to have a baby, maybe 6 to 8 months later on after your marriage, after you have enjoyed your initial period of your marriage, then you please come to me before 3 months so that I can give you the necessary folates and take the necessary assessment that is required for you. Women who thought that they were pregnant, but they had a negative pregnancy test. It's very common in today's scenario of aggravating PCO, that she has amenorrhea for 2.5 months, and then we find out, okay, she's having a negative pregnancy test, but then we need to take this opportunity here that, okay, you are having a hormonal disbalance. Please rectify it prior to becoming pregnant so that you have a viable embryo at the end of the day. Women who have just had a spontaneous abortion, we need to find out what was the reason. If she has come for a spontaneous abortion, we have done a suction evacuation. This is not where our duty as a clinician finishes. We need to just explain that female in particular detail that, okay, there was certain pertinent reason why this baby has not gone to the 9 months duration. Why have you lost the baby at 2.5 or 1.5 period of gestation? We need to tell her that there are 5 important causes. There might be some infection, there might be some immunological cause, there might be some anatomical cause in the uterus, there might be some hormonal disbalance, there might be some blood flow disorder, there might be some thrombophilias. So we need to understand and make her understand that, okay, prior to taking up a next pregnancy, you need to assess yourself on these particular facts and then go ahead, so that next time when you become pregnant, you have a viable baby rather than losing it once again. Women undergoing infertility treatment, definitely these are the ones who are high risk people, because these are the ones who are coming to us at an advanced age, more than 30 years of age, having multiple other hormonal imbalance disorders and maybe other metabolic issues also. So we need to actually assess these particular clients who are coming from infertility management. These are the particular windows of opportunity that we clinicians should take part in doing a PCC. Why is PCC counseling so very obscure with clinicians? We are not actually doing it because we are busy. We are busy with 100, 150 patients in the OPD every day, 10 to 12 OTs in the OR. So our majority of the pregnancies, they are still unplanned because we have not taken opportunity to tell them, though, okay, please plan the pregnancy. Globally, around 38% of pregnancies are unintended. There's ironical statistics in this today's world of so much of literary advancement and lack of awareness on the significance of preconception counseling in the common masses needs to be addressed. Every clinician should take up this. What I feel is that this lack of awareness has to be, there's a light of awareness has to be instilled into the common masses that, okay, PCC is a very, very important aspect to improve the maternal and perinatal outcome. So when are we actually going to do the PCC? Ideally 3 to 6 months before the actual attempts are made to conceive. And this is a time frame when a woman is allowed to better prepare herself for a successful conception, better prepare her own body for a successful conception, and allow her to reduce the modifiable risk factors. The risk factors can be modifiable as well as non-modifiable. A modifiable risk factor is such as if she is having increased weight, she can definitely cut down on weight and then go ahead with the pregnancy when a BMI is normal. Something which is non-modifiable, like a genetic predisposition that we cannot modify, but we can definitely change her lifestyle so that she is is at decreased risk whenever she is going to become pregnant, and her risk ratio regarding those metabolic disorders, even if she is genetically predisposed, becomes lesser. Now, in steps of preconception counseling, we just need to prepare our body for a new life. That is the entire conception that we want to actually emphasize upon, that your body is not ready for a new life, just don't conceive. If your body is ready for a new life, go ahead with it. You identify all your pre-existing risk factors, you identify all the potential risk factors, you screen the woman for common medical disorders which may have an impact on the pregnancy. Very commonly, as I've already said, diabetes, hypertension, thyroid, PCO. We can just go for a genetic counseling if required. If she had a repeated history of miscarriages, a nutritional counseling is definitely also is of very pertinent use. Our goals for preconception counseling, as per the Centers for Disease Control and Prevention and Select Panel on Preconceptional Care, is that we need to improve the knowledge, attitudes, and behaviors of men and women related to preconception health. We need to assure that all women of childbearing age is receiving preconception care services based on evidence-based screening, health promotion, interventions that will enable them to enter pregnancy in optimal health. Optimal health is the word that we need to emphasize upon. Reduce the risk indicated by previous adverse pregnancy outcome. This I've already said, that if she had a miscarriage, just not a suction evacuation finishes your job. You need to, through thorough interventions during the interconception period, this is a time when you take out this opportunity in the interconception period, that okay, we can prevent or minimize health problems for the mother and her future children, and we need to reduce the disparities in adverse pregnancy outcomes. The key components of preconception care is reproductive life plan, past reproductive history, medical assessment, medication use, infections and immunizations, which will be going into thorough details in the slides to come, genetic risk, the healthy weight and nutrition, psychological and behavioral risk, healthy environment is a very, very important take out here, that we need to have a healthy environment for the female in the family as well as in the social arena, and the physical assessment is of utmost importance. It should be included in the basic and in-depth information regarding the female. How is her lifestyle? How is her diet? Whether she is exercising daily, whether it's taking a lot of undue stress, whether how is a family history, how is a personal history, whether she is having any drug abuse, smoking, alcohol abuse, whether she's having any pre-existing morbidities, whether she has been screened for diabetes, hypothyroid, hypertension, and whether she's having a normal BMI. The folate supplementation is, as we all know, universally know, that it is very much required, and the maternal undernutrition and iron deficiency anemias need to be rectified prior to she becomes pregnant. Why is preconception counseling so significant? Because there are certain things that we are not, as obstetrician, we have been always very much afraid of, like preterm birth. We are not able to, once the labor pain starts at the 7th month, we can do nothing but just wait and watch. So this is something which is preventable in many scenarios. Like in case we have a proper PCC, we can reduce the preterm birth ratios by a lot many ratio number, and fetal growth restrictions can be definitely reduced. Congenital anomalies and perinatal and maternal morbidity and mortality can be significantly reduced. If we identify the pre-existing risk factors, there's the age, adolescents and teenagers. This is a time when we should actually start PCC, because what I feel, a healthy female, a healthy young female, an adolescent female is going to be a healthy mother in the near future. So it's a generational work. We need to work with the adolescent and the teenager females. They're more likely resulting in low birth weight females. These are the ones who, if become pregnant, these teenage females will be more likely to result in low birth weight infants along with prematurity when they become pregnant. So whenever a girl of having a menorrhagia or maybe a PCO or maybe a dysfunctional bleeding comes to us at the age of 18, 19, if she's married and she just wants to say, okay, her family is wanting a baby now, just tell her that, okay, let's just pass on the age of 20, 21 and then go ahead for a conception, because this is not the right time for you to conceive. You're still a teenager and there might be chances that you might end up into having a low birth weight baby. So, and also prematurity is of high risk in such cases. So this is the time when you take that opportunity to tell her, but you have to be very, very vigilant and very, very precautious during telling her this, because she might otherwise get annoyed what the doctor is saying. I've come to her for a bleeding period and she is telling me about pregnancy. So you need to be very tricky in such situations. Women after 35 years of age is more prone to have chromosomal anomalies, as we all know. Miscarriages, fetal aneuploidies and coexisting medical conditions are really very high in such cases. So these particular females, they are usually coming to a fertility clinic. So we need to take this opportunity to counsel them as well. Regarding the medical history, a detailed, thorough history regarding prevailing asthma, the risk of thrombophilias, hemoglobinopathies. In our state, Assam, we have a very common hemoglobinopathy here is hemoglobin E disease, which is common in almost as high as 60 to 70% of Ahom population. The main population that had made Assam rise from the very Esther years. This was a main Ahom kingdom here, and this was the population which were having a lot of hemoglobin E. So it is still prevailing in our state, and we are checking for hemoglobin electrophoresis in almost all cases who can afford it, who are coming to our antenatal clinic. If we get a hemoglobin of around 9.5, we make sure that we are checking their hemoglobin E status, because it's so very common in our state. The autoimmune diseases like SLE, diabetes mellitus, hypertension, DVT, epilepsy, and an array of cardiovascular diseases, PKUs, renal diseases, and malignancy screening. If we go ahead with the family history, we need to understand whether her father is diabetic, her mother is diabetic, and his sibling is diabetic, whether she is having any history of congenital anomalies in the family. A genetic counselor can also take play into this, whether she is having any mentally retarded sibling, whether thalassemias, and husband's family history is also very, very pertinent in this case. Regarding a detailed reproductive history, menstrual history is of utmost importance, whether she had regular periods, irregular periods, how was the flow, how was the duration, what was a cycle length, everything has to be taken note of. A pertinent detail including a history of infertility, miscarriage, ectopics, RPLs, and PTL, as I've already mentioned. Complications of previous pregnancies like preeclampsia. If she had a previous pregnancy where she ended up into having a hypertensive disorder of pregnancy, we need to assess whether she will have a recurrence in this pregnancy as well. Whether she had a history of placental abruption in the previous pregnancy, there are chances of recurrence in this one as well. History of cervical as well as uterine anomaly, they may lead to a premature labor or a preterm labor. There's a details of perinatal period. Indication of previous cesarean section is also very, very important. Whenever we ask a female that, okay, suppose there's a female, there's a gravita, there's a female who is coming to us for a irregular bleeding PV. We are asking how many children you have. She says, I have one child. So when we say, when are you planning for the next? She'll say, I'm planning on maybe another 1 or 2 more years. So we don't take this note to ask her what was the reason that she had the first cesarean section done, whether it was an elective, whether it was an emergency CS, whether she had a PROM, whether she was a prolonged labor, whether she was obstructed labor, whether she had any other obstetrics or maybe a pelvic cause of getting the CS done. So we need to put it into detail and documentation that this was the indication of a previous cesarean. Just writing first baby by LSCS is not enough. If we want to go for a proper PCC, we need to know what she had all undergone during her first conception, and whether there was any need of the baby admitting into an ICU. That is also very important. Why at all did the baby need an ICU management? Whether the baby was small for gestational age as respect to other babies. And the drug history is also very important, because women who are on ACE inhibitors should be switched over to safer antihypertensive. This we all know. Over-the-counter drug use should be condemned. Anti-epileptic drugs, if any, to be considered, and safety profiles to be discussed with the client and also with the neurology person who is dealing with her. Women with diabetes mellitus should be given contraception till the glycosylated hemoglobin falls below 6. This is very universal, very much pertinent to our country to prevent all those organogenesis problems during the first 3 months of fetal life. So we need to really emphasize on this particular fact that the glycosylated hemoglobin has to be below 6 if the female with diabetes wants to go ahead with conception. Regarding immunization, we need to check her Hep B status, and there's a lot of hue and cry revolving around the rubella. There are doctors, there are consultants who are checking the TORCH test, and then once the TORCH test is find out to be, if you find out a rubella IgG positive, they jump onto treatment and ask the client not to conceive. So I just want to clear here very, very pertinently that please check for the TORCH infection test only if you know how to interpret the results. It is very, very important that if you do not know how to interpret the results, if you overdo, it is really, really going to be a havoc. Whereas if you're getting a TORCH test done, if you get a toxo IgG positive, there's nothing that you need to do, even if the patient is not pregnant, even if she's pregnant. If you're getting an IgM positive, definitely if she's pregnant, you need to treat her. But if she's not pregnant, even if the IgM positive has to be repeated repeated again after 2 to 3 weeks. If you're getting a rubella IgG positive, please don't do anything. She is immune. She is rubella immune. So leave her like that. Counsel her that IgG, if it's positive, you have been vaccinated maybe earlier, or she might have had an infection which has made us positive, and she can go ahead with the pregnancy without any doubt. If she's having an IgM positive of rubella, please go ahead and repeat the test after 2 to 3 weeks. Get her treated with acyclovir required if the repeat test becomes positive. If she is IgM positive, this is what you're going to do. But if she is IgG and IgM both negative, please vaccinate her for rubella vaccine. Please give her an MMR and then ask her not to go ahead with the conception for 1 month, and then she can definitely go ahead with conception, because it's a live attenuated vaccine and she needs to develop that amount of immunity over a period of 1 month. And however, if inadvertently she becomes pregnant within this 1 month of your vaccination schedule, then she has to not be terminated. She doesn't require a termination, but a thorough counseling is very much required, that this was a live attenuated vaccine. You have been asked not to become pregnant. Put it on pen and paper that, okay, have she become pregnant? The counseling regarding the risk ratios and the associated anomalies has to be explained to her in black and white. So this is very, very pertinent, that if you are testing for all those intrauterine infection thing, if you're testing for the stores, you need to understand and interpret the results in a proper manner. The socioeconomic evaluation of the status of the female is a huge impact on the pregnancy outcome. If you check about the nutritional status, the hemoglobin levels, the pre-pregnancy weight, this all has an array of effects, a string of effects on the pregnancy outcome. The iron deficiency anemia should be treated with a 50 to 60 milligram elemental iron, best taken between meals. A potential teratogenic exposure to heavy metals and pesticides and organic solvents, in case the female is coming from a lower socioeconomic strata and she has been living beside some factory or beside some area where she has been working day and night into that factory, or something which is really having a lot of passive smoking in her life. So this is all very, very pertinent. If we want to talk about pre-pregnancy weight and the dietary habits, we need to understand that the BMI 25 to 29.9 is overweight. And if she's obese, having a BMI more than 30, she's advised to lose weight before pregnancy, because this will again have an impact on her metabolic disorders associated with pregnancy. Healthy weight reduces the risk of neural tube defects, preterm labor, gestational diabetes mellitus, in fact, more of reduction in the rate of cesarean delivery, hypertension, thromboembolic disease, everything will go into an nullification effect. And the vitamin D deficiency, definitely in vegans, is a very, very important issue to cater off, and the role of nutritionist also has to be taken care of. If we talk about her behavioral details, we need to understand whether she is having a one sexual partner or having multiple sexual partners to actually assess for her venereal diseases. We need to assess this, because in today's world of more modernization, we get females having 2 to 3 sexual partners and they do not even know whose baby is that. So this is a very, very important social issue that we need to, that this conundrum around female health has to be addressed in proper detail and with the proper risk evaluation. So alcohol and tobacco abuse, intrauterine growth retardation, miscarriages, preterm labors, stillbirths, and placental problems all need to be assessed in details. There's improvement of emotional well-being of the woman is very, very important, because not only the woman needs a tender love and care when she's pregnant, but when she's preparing her body for a pregnancy, this is a time when we need to actually show that we care. And when she becomes pregnant with a positive mindset, this is when we can have a more healthy mother and a baby outcome. Exercise in pregnancy is of paramount importance, and a regime of stretching, walking, and mild aerobics should be routinely followed. There's a very important thing that I want to emphasize: the short interval pregnancy. A short interval pregnancy is the time when the interconception period is the time when the female's body is going to replenish her own sources to become pregnant again. And this is the time, if this spacing is less, less than 18 months, then we cannot give her that optimum health that we are actually considering in. So associated with preterm deliveries, PROM, maternal morbidity, mortality, and third trimester bleeding, as well as anemia, and thorough counseling to avoid short interval pregnancy should be done in all females. If they have had a previous section or a previous normal delivery, even, we need to tell them that please do not become pregnant for the coming 1.5 to 2 years until unless all sources of your body is replenished. The prevention of neural tube defects, the first occurrence can be reduced by intake of 0.4 milligram of folic acid daily 3 months prior to conception. This is one thing. NTD is one thing which since the yesteryears we have been listening since our undergraduate days that okay, preconception counseling or preconception folates has to be given for NTD. This was one thing that always in the books have been emphasized, that preconceptionally folic acid has to be given to prevent NTDs. But what we have discussed today is an array of socio-economic, physical, mental, emotional well-being of the mother to have a healthy child. So this not only NTD, we need to know the doses of the NTD. Women with prior history of NTD or non-anticonvulsive therapy should be supplemented with 4 milligram of folic acid preconceptionally. And the lab investigations that we can not a very area of unnecessary investigation that will be not more cost effective to the client. We can go ahead with a complete hemogram, a fasting blood sugar, and a 75 gram 2-hour GCT in our country, and TSH and free T4 levels, the serum creatinine. Definitely a pap smear is also of utmost importance in sexually active females, and HBS antigen, VDRL, and HIV status. The usual questions that we usually can face after having this particular discussion on PCC is that is the counseling best targeted to the general population or to some specific subsets? I take this opportunity to tell you all here is that I take the opportunity to counsel each and every client who steps into my chamber. I just make a note that, okay, she comes to me for a preconceptional counseling. I just write on the prescription proper one particular line that whenever you want to become pregnant, please come to me 3 months prior to your planning. And this is what they follow even. If they complete the course of the medicine which they had been given for the prevailing ailment, and then they go back and read the prescription, they have it in my mind that, okay, ma'am has written something at the bottom which really is necessary maybe. So after 3 months of completion of that course, they usually come back and ask, ma'am, what was this that you have written? So that is a time when we can take this opportunity. Okay, you can come for a PCC, you can evaluate yourself and then go ahead with the necessary conception whenever your body is fit, your mind is fit, and your body is actually allowing a new life to come in. Offered as a routine component or a delegated to special visits? No, it is not delegated to special visits. Every visit has to be taken as an opportunity to take this routine PCC. Do all potentially fertile women need preconception counseling? Yes, definitely. If all reproductive age of a female wanting to become pregnant or wanting a pregnancy in the near 1 or 2 years time, that should be taken up an opportunity for a potentially fertile woman to go for a PCC. Is it cost effective? Yes, definitely. We are not going to this array of investigations and harass the client with an unnecessary investigation. We're doing the basic hemoglobin levels, the basic TSH levels, the basic random sugar levels, and the basic hormonal disorders. So we just taking the basic investigation. Definitely it's cost effective. What is more important is that you're counseling the client prior to doing that, and they're definitely ready to do all those. How can a busy provider? The most important question here is how can we busy care providers? We have so many Zoom meetings to attend, we have so many ORs to do, we have so many labor rooms, we have so many OPD patients waiting for us. We are even we when we are doing an IUI, at times we compromise on the IUI specimen that okay, I finish 2 more clients and then I go for a insemination. So this is where we are actually comprehending that whether a busy care provider can incorporate this prevention emphasis into the routine encounters. So what I want to say is that just hardly takes 30 seconds to 1 minute. Just tell them that come to me when you want to have a pregnancy. Just this line or mention it in your prescription. Please follow PCC. The take-home message that I want to give here is that preconception counseling gives us opportunities for disease prevention and health promotion. This is something, Garva Sanskar, the fetal origin of adult diseases. All diseases that a matured person has to suffer in his adult life, somewhere or the other, the origin is into the fetus. So this is where we want to actually grab the opportunity to prevent those diseases and promote a healthy life for both the baby and the mother. Improves family planning and pregnancy outcomes. It enhances reproductive health and preparation for parenthood. And the holistic approach of preconception care involves pre-pregnancy planning, including nutritional, emotional support, diseases and addiction, and socially accepted relationship, financial independence, healthy environment, violence prevention against women and girls, educational and professionalism. Everything has to come into account. This is something which we need to approach holistically. This should be the picture for every female whenever they're becoming pregnant. Should be a news that she is is happy to share with, and something she is not shocked of. The first time she gets those 2 lines, it should be a matter of sheer joy for her and utter pleasure that she needs to share with everyone around, and not something that she needs to hide back, and that, okay, I have become pregnant, I was not ready for it, now what to do? Coming 6 weeks, I am having a havoc of a time till I get the first viability scan. So I just want to emphasize is what, why, and how of a preconception care. Healthy minds and bodies have healthy moms and babies, and this is a generational work that we'll be doing right from adolescent to pre-pregnancy and a reproductive age female to have a better maternal and perinatal outcome. Thank you for your patient hearing, and have a pleasant evening. Thank you.
Thank you, Dr. Prerna. She has explained very nicely. It was an excellent presentation by Dr. Prerna about preconception counseling. Basically, in her take-home message, she has explained very nicely. This is prevention and health promotion. I think it includes all. She has explained very nicely in each slide all the diseases we can take care of with diabetes, hypertension, hyperlipidemia, and all that, and genetic diseases. And she has explained very nicely key components of preconceptional care. Then, to reduce morbidity and mortality, and it has been documented that preconception counseling and care will reduce maternal mortality rate also. It helps. She has explained very nicely the role of diagnosing HBE disease, drug history, exercise, behavioral history, and NTDs. Thank you so much, Dr. Prerna. It was excellent presentation. Thank you so much.
Thank you, sir. Thank you, sir.
So after that wonderful talk, we'll move on to the next speaker. We have Dr. Varsha Baste ma'am with us. And to introduce her, request Dr. Sagar Kataria to please do the honors.
Good afternoon, everyone.
Sir, please unmute us.
Yeah, am I audible?
Yes, sir, please go ahead.
Good afternoon, everyone. Many thanks, Dr. Pratik Tambe, convener of today's program, for inviting me to this session. Thank you, Dr. Rajendra Singh Pardesi and Dr. Ameya Purandare. I have a pleasure to introduce today a versatile personality and a dynamic personality, Dr. Varsha Baste. She is practicing for last 27 years, and she is director at Pushpa Fertility Center, Nashik, since 18 years. She has done first ICSI PGD baby in North Maharashtra. She is founder member of ISR. She has received a prestigious Dr. Anandibai Joshi Award. She was felicitated by many awards like Tejaswini Award. She was chairperson at West Zone Infertility Conference for IFS in 2014. West Zone UFOXI was held during her presidential tenure in Nashik. She was past president of OBGY Society in Nashik, and at present she is chairperson of FOXI IAC committee. The ever smiling and the grand personality, Dr. Varsha Baste, the screen is yours.
Thank you, Dr. Sagar Kataria, for such a nice and warm introduction. I'm really obliged. Thank you so much. At the outset, let me thank Dr. Nandita Palshekar, our such a loving Vice President, Dr. Rajendra Singh Pardesi, always supporting and so warm person. And I really love Dr. Pratik Tambe. He's so energetic, and endocrinology is really boosted under his committee chairpersonship. Among them emerged as a big organization under the guidance of Dr. Nandita Palshekar, also Ameya Purandare. What should I say about him? I am the disciple of Dr. B.N. Purandare, and I have seen him growing when he was in childhood. And I am really thankful, Dr. Pratik Tambe and Amox, for giving me this opportunity. So I will share my presentation. So my presentation is on the role of insulin sensitizer in PCOS. Now, friends, yes, my presentation is role of insulin sensitizers in PCOS. Friends, we all know what it is, and we all have discussed it for a longer time and many times. Everybody knows we are using metformin, minoxidil, diclofenac, everything n number of time, day in and out. But still, there is something we want to know more and more about this PCOS and the treatment with the insulin sensitizers. So, what is PCOS? We all know that, but most common endocrine and metabolic disorder in women of reproductive age. It's very common cause of infertility in women, characterized by hyperandrogenism, chronic anovulation, and polycystic ovary with exclusion of other etiologies. So prevalence in India, more than 36% of women are suffered with PCOS, because this is the capital of India is the capital of diabetes, hypertension, and whatnot, NCDs. And global prevalence is up to 26%. So we are number one, I will say, in PCOS on the world map. So what are the signs and symptoms of PCOS? Because this is so common, we have to explain it again and again. We want to know again and again, and we want to get updated again and again, even if we know everything about it. Acanthosis nigricans, we all know, acne, hyperandrogenism, hirsutism, obesity, and the anovulation. So, pathophysiology of PCOS is the pathophysiology of PCOS, insulin, very important. That's why the topic is insulin sensitizers. Insulin hyperinsulinemia is very crucial, and that is the culprit. Ovarian follicular disease is hampered, that is causing menstrual irregularities, and gonadotropin secretion causes hyperandrogenism from the adrenal gland as well as from the ovaries. So, what is the pathophysiology? The androgen of the hypothalamic pituitary ovarian axis is affected, and the abnormal GnRH pulsation causes abnormal gonadotropin levels, increased LH-FSH ratio that affects the ovary, and so there is ovarian dysfunction. And this insulin resistance causes insulin resistance of muscle and liver, adipocyte dysfunction, hyperinsulinemia. So pancreas is also affected, and there is a mahapur of insulin. And even if so this all will affect the adrenal. So the ovarian dysfunction causes follicular arrest, or the abnormalities, or the less quality of oocyte formation and PCOM. And the HSPC levels are reduced in production is reduced in the liver, and adrenal androgens are increased. So what is the diagnostic criteria? We will take only one. We will not discuss what was now, and we will not discuss about it, but Rotterdam, X-ray, and ASRM diagnostic criteria we are following now. So out of 3, only 2 should be there, like hyperandrogenism, clinical or biochemical, it should be diagnosed, chronic ovulation, and USG should show 12 or more follicles measuring 2 to 9 mm of diameter, and the increased ovarian volume more than 10. So what is the algorithm? Patient with PCOS relates with infertility. The lifestyle changes, healthy diet, and regular physical activity definitely can lead to ovulation induction. Letrozole is a first line, clomiphene is a second line, gonadotropin is a third line, but before that, we have to add metformin and insulin sensitizers as a first line of treatment. And then if the AMH is more than 11, 12, then we can think about the laparoscopic ovarian dealer, or even if she doesn't respond to insulin sensitizers or oral ovulagens, or the stimulation protocol, if they fail, then we can think about the last, like laparoscopic ovarian drilling. Now, let us see there are 2 parts, during not pursuing pregnancy and for pregnancy. So, treatment for adolescents and lean women. This is a large group who do not want to become pregnant, but they are having PCOS. So, what should they do the treatment? The PCOS treatment should be individualized based on patient's presentation and desire for pregnancy. Lifestyle modification, we all know it, first step of therapy. Even if she reduces the weight by 5 to 10%, over 6 to 12 months, it will give her better results for good ovulation and normalization of the menstruation. Nutrition, caloric index restriction is important to achieve the BMI. Exercise minimum 150 minutes per week of moderate intensity exercise or minimum 75 minutes per week of vigorous exercise or combination. Or she can also use weight training, muscle strength activity for at least for 2 days. So what is the role of insulin sensitizers like addition of metformin and minoxidil or minoxidil and D-inositol? So metformin definitely reduces the weight, decreases the hyperinsulinemia. So it is like target treatment, reduces androgen levels, restores ovulation, higher pregnancy rate and live birth rate because the oocyte quality is better. First line medication for metabolic manifestations such as hyperglycemia. Now this minoxidil and D-inositol combination 4:1 ratio is very, very important because it is disturbed during PCOS. So what are these? These are the antioxidants which are naturally present in the body, but in PCOS because they are more than 6 times it is washed out in the urine, so the ratio gets disturbed. So we have to balance that ratio, and then it gives improved insulin sensitivity, decreased serum androgen concentrations, increases sex hormone binding globulin from the liver, improve oocyte and embryo quality, and maturation of oocyte is very well achieved with this combination, improves menstrual cycle and improved fertilization and pregnancy rates. So this combination of metformin, add-on minoxidil and D-inositol in 40:1 combination shows significantly better result in weight reduction, ovulation, pregnancy rates than only the use of metformin alone. So this is the first line of treatment in PCOS. So what is the treatment for hirsutism? Minoxidil and D-inositol improves hyperandrogenism. Substantial reduction in hirsutism score. There is a reduction of hirsutism up to 16 to 30% with the use of this combination. Reduction in serum androgen contraction and concentrations of ovarian and adrenal origin also. Simple and safe treatment that ameliorates the metabolic profile of patients with PCOS, reducing hirsutism. So what is the treatment now? We have seen lean and adolescent girls. Now the women who are suffering from infertility due to PCOS, they want to have pregnancy. So what is the treatment? Preconceptional counseling. We have just attended a very nice elaborate lecture by Dr. Prerna Keshan. Lifestyle modification, optimizing weight with diet and exercise is utmost important. And then she has also told us that to add folic acid, that is also very, very important. Because folic acid, what it is vitamin B9, and it is very, very important for the DNA structure of the every cell. So we have to give it along with the lifestyle modification. Ovulation induction. It is done with metformin. Higher rates of ovulation, clinical pregnancy and live birth rate can be achieved with use of metformin and in combination with D-inositol and minoxidil. A new line of treatment is inositol, minoxidil and D-inositol. Significant improvement in ovulation rate, regularizes menstrual cycle, increases clinical pregnancy rates and lowers the total efficacy dose. See, the minoxidil acts at the level of ovary and D-inositol acts at the peripherally, like insulin resistance and insulin sensitivities. It controls that. It controls it. So, and another this N-acetylcysteine. See, the hyperhomocystinemia is very, very bad for infertility. The homocystinemia, this homocysteine is converted to cysteines with the help of vitamin B6. So this is a amino acids, very good antioxidant needed for the growth of the follicle or folliculogenesis, and so it is very effective in inducing and augmenting ovulation in PCOS patient. Vitamin D, we all know it is very, very important. The therapeutic adjuvant for ovulatory dysfunction and metabolic disorders and very important for correction of vitamin D levels for the treatment of PCOS. L-methylfolate, that is vitamin B9. It is water soluble. Patient has to take it daily. And also the tetrahydrofolate is very, very important. If you give only the folic acid, it will just go and accumulate in the body without metabolized with particular enzyme, and so there is a high rate of concentration which is not of use. We have to use directly tetrahydrofolate, which is directly absorbed, and it is used to avoid all the complications. And melatonin is also very, very important. So this is used for ART like IVF, ICSI, IBM, and laparoscopic ovarian drilling is the last resort. Now, the correction of obesity, insulin resistance, and PCOS. 50% of patients suffer from obesity of the PCOS patient. Of them, 80% are hyperinsulinemic to have insulin resistance. Independent of obesity, even if they are lean, they may be having insulin resistance or hyperinsulinemia. This hyperinsulinemia contributes to hyperandrogenism through production into cells and through its suppressive effect on sex hormone binding globulin production by liver. So this diagram is telling us about the hypothalamus, GnRH, and inappropriate increase causes pituitary ovarian axis disturbances. So increase in LHFSH, pancreas is also affected, which affects the insulin resistance, hyperinsulinemia, because stomach secretes the ghrelin, which is affected due to androgen excess, and this leptin decrease or increase, it affects the appetite. So that's why the PCOS patient have the craving for food. Always they want to eat something sweet, and that adds on. So sugar and this refined flour is big no-no for such patients. And the fat cells accumulation causes obesity. And this androgen excess, this all gives the negative feedback, and this hyperandrogenemia causes PCOS, and likewise the vicious cycle is going on and on and on. So insulin resistance, the pathophysiological contributor is 60 to 80% of 60 to 80% of PCOS women suffer from insulin resistance. And 95% of patients who are obese with PCO have insulin resistance. So that's why we have to use insulin sensitizers. So role of insulin sensitizers. So this is a bar diagram I am telling you. Insulin sensitizer increase the sensitivity of insulin towards the receptor, thereby decreasing hyperinsulinemia. And this PI3 kinase enzyme is very, very important, and it is decreased because in PCOS patient, that is needed for GLUT4 for conversion to glycogenesis to glucose. So this is like secondary messengers impact on PCOS. PCOS may have defect in secondary messenger contributing to insulin resistance. So deficiency of inositol decreases PI3 kinase activity. So this is very, very important chain which is leading to PCOS. The patient becomes PCO patient. So this insulin and this receptor, it gets converted to GLUT4 and with translocation, the glucose is used for metabolism and for the body energy. So what is the glucose metabolism? We have just seen the flow diagram. Insulin binds its receptor and forms a complex called insulin receptor substrate, IRS. This IRS stimulates enzyme PI3 kinase and MPK. Activated P3PI3 kinase activates MPK, which stimulates GLUT4. Glucose is then taken by GLUT4 through glucose channel for utilizing energy, and some gets converted to glycogen. And then this insulin receptor substrate complex breaks down, and again the receptor relocates back for its original site to receive insulin. Myoinositol, it is a new ray of hope. It is a new ray of hope. We are using it left and right, but is it good? Is it not good? Let us see that in little detail. Inositol both produces and activates PI3 kinase enzyme, and so it is like a precursor of this enzyme. It belongs to vitamin B complex. Vitamin B complex is very, very important. I tell you, vitamin B6, B9 and B12. Very, very important for patient becoming pregnant. Even if you use calcium, make sure that it has all these components so that she gets it throughout the pregnancy. So myoinositol is a B complex. Two inositol isomers are proven to be insulin mediators like myoinositol and D-chiroinositol. And this secondary messenger to insulin and FSH, inositol both produces and activates PI3 kinase enzymes. And this is directly involved in insulin cellular signaling. Oocyte maturation is very, very important, cell growth and differentiation. So inositol insulin sensitization mechanism. So we have just seen this flow diagram, insulin and this receptor. This is a substrate, and the myoinositol increases the PI3 kinase because it is a precursor and AMPK, and thus this flow chart becomes complete, and so the insulin resistance is decreased, and so there is no hyperinsulinemia. So benefits of myoinositol and D-chiroinositol: metabolic abnormalities, improves insulin sensitivity, decreases BP, decreases BMI and fat mass. Hyperandrogenism is decreased significantly and increase HSBC from liver. Means that naturally the menstrual cycle ovulation will regularize, improves menstrual cycle and improves ovulation rate. So I think that it is clear now. So what is the rationale of using metformin plus myoinositol plus D-chiroinositol, that 2:40:1 ratio? What does metformin do? It activates insulin receptor expression, improves insulin sensitivity, activates AMPK enzyme, decreases gluconeogenesis and reduces androgen level. Very good. What does myoinositol do? It acts at ovary, increases glucose cell intake, activates PI3 kinase enzyme because it is also the precursor of this enzyme, secondary messenger for FSH signaling, increases oocyte quality and maturation. D-chiroinositol acts at peripheral tissues, stimulates glycogen synthesis, reduces insulin resistance, increases insulin sensitivity, reduces hyperinsulinemia. So metformin with myoinositol with D-chiroinositol, particular combination 40:1 is beneficial for improving metabolic, hormonal and reproductive aspects of the PCO patient. This combination induces significant body weight reduction. So this is the data of 150 Lebanese women. 2 tablets were given of this combination per day to them for 6 months, and significant weight reduction up to 4.6 to 5 kg was achieved. 86 women were subjected to the RCT. This is a RCT of 84 women without hyperinsulinemia, and the quality of embryo was definitely improved. Now, the number of patients in this study is 320. Metformin as a placebo, metformin 1000 milligram 2 times a day was given in identical doses of placebo, and up to 49% of the pregnancy could be achieved only with the metformin. Now, if we give metformin 500 milligram plus myoinositol 600 milligram 3 times a day, and with placebo with one group was received only metformin 500 milligram 3 times a day, 55% women could get pregnancy with this combination. So it is definitely added advantage. Now metformin induces significant reduction in body weight. So this is the 6 randomized placebo-controlled studies, and that has proven that definitely metformin plays a big role in correcting the BMI. Metformin, insulin sensitivity and HOMA index and decreases both insulin and BMI. 50 overweight patients were given myoinositol 2 grams per day, and group B was given folic acid as placebo for 12 weeks, and definitely the body mass index was reduced. And that was 56% reduction in the body mass index. Also, we have just seen that myoinositol and D-chiroinositol combination improves the maturation of oocyte and quality of oocyte. So metformin is a drug of choice to treat obese and infertile PCOS patients. However, few patients are really intolerant to metformin. Everybody is here. The clinician knows that even if we want to give them, they cannot tolerate, and we have to abandon the treatment. So 45%, more than 45% of patients complain of diarrhea, abdominal pain, bloating, heartburn, indigestion, vomiting, all sorts of gastrointestinal problems. So PCOS is characterized by reduced level of inositol. 6 times more urinary clearance of dihydroxyuretol in obese patient compared to normal women. So deficiency of dihydroinositol in PCOS patient occurs because it is excreted through urine. And this combination of this ratio is altered in obese PCOS women. So we have to correct it by adding it. So alter this myoinositol and dihydroinositol ratio causes poor glucose uptake and utilization, in use insulin resistance, hyperinsulinemia, and that also causes hyperandrogenism. So PCOS is characterized by reduced levels of inositol. So what is the treatment? Add it. It is a natural antioxidant. Alter myoinositol and dihydroinositol ratio in PCOS patient causes hyperinsulinemia, enhanced epimerization of ovary, decrease myoinositol and increased dihydroinositol, causes the myoinositol deficiency in follicular fluid, impaired FSH signature, and so poor oocyte quality. If we correct the ratio, there is overproduction of dihydroinositol in ovary. So we have to use 40:1 ratio. So oxidative stress in polycystic ovarian syndrome, insulin resistance contributes to oxidative stress. See, this insulin resistance will lead to obesity, will lead to androgen excess, and so there is visceral adiposity, and the oxidative stress is increased, and increased insulin resistance, which is very, very bad for the body. So we have to reduce it by using myoinositol and dihydroinositol. Myoinositol, again, we will see this slide as a revision. It acts at ovary. Myoinositol is FSH second messenger. It increases FSH signaling and improves oocyte quality and oocyte maturation, whereas dihydroinositol acts peripherally, stimulates glycogen synthesis, reduces insulin resistance, and increases insulin sensitivity. So this N-acetylcysteine. What is it? It is a amino acid. It is very, very much needed. See, homocysteine is converted to cysteine with the help of vitamin B6. So we have to adjust the concentration of this N-acetylcysteine, then only the DNA is protected and good oocyte formation can occur. So this N-acetylcysteine is very important. It inhibits oxidative stress and prevents hyperglycemia-induced insulin resistance, lowers androgen level, improves ovulation, pregnancy, and live birth rates. And this prevents follicular atresia at the level of ovary and regulates. So the apoptosis is prevented with N-acetylcysteine. It regulates menstrual cycle and provides immune suppression. So what is the treatment of PCOS? Correction of the deficiency. And that too, antioxidants, they are very, very good amino acids, cysteines, antioxidants. So it is not at all harmful. So if the patient is very much sensitive to metformin, because of all this gastrointestinal disturbance, you can shift over to at least to this combination of myoinositol and dihydroinositol and add N-acetylcysteine. It increases glutathione at cellular level, acts directly on reactive oxidant radicals. It has got very good antioxidant effect and exert protective effect on two cells, and so the cells are protected and normalization of the oocyte maturation can be achieved. So this improves ovulation, this inositol and N-acetylcysteine combination improves ovulation rate naturally because the natural formation of folliculogenesis occurs, and the luteal ratio and menstrual cycle restoration can achieve with the natural ovulation. Now this is the very important slide. We all know we are using vitamin D in PCOS patients. So what is the role of vitamin D? 45 to 90% are of PCO patient are vitamin D deficient. PCOS and vitamin D deficiency are associated with insulin resistance. Therapeutic adjunct for ovulatory dysfunction and metabolic disorder, vitamin D supplementation is very important. It stabilizes the hormones, normalizes the menstrual cycle, and restores ovulation. Improves insulin resistance, helps to increase longer maintenance of ovarian reserve, and decreases the androgen levels in PCO patients. So vitamin D in PCO patient increases HSBC, increases insulin sensitivity, correct metabolic syndrome, regulates menstrual cycle, regulates androgenism, and so patient can have good fertility potentials. So friends, in a nutshell, what is the take-home message of insulin sensitizers? PCOS is a very common endocrine and metabolic disorder in women of reproductive age. Lifestyle modifications are very important, like weight loss, increased exercise if overweight and obese patient is highly recommended. Metformin with myoinositol and D-chiroinositol combination is preferred for women with insulin resistance, and it doesn't harm because they are naturally present in the body also, except metformin. Metformin, myoinositol with D-chiroinositol therapy in 40:1 ratio is very, very important, should be considered as first-line treatment for PCOS. Myoinositol and acetylcysteine have emerged the novel pharmacotherapeutics to improve IVF outcome for treatment of infertility, to improve the follicle quality. And this N-acetylcysteine is powerful antioxidant, inhibits oxidative stress, prevents hyperglycemia, and thus prevents the apoptosis or follicular atresia at the level of ovary. Supplementation of vitamin D deficient patients is very important, and laparoscopic drilling, if ever we want, if all these stuff fail, orally ovulation induction along with these insulin sensitizers, and the AMH is more than 11, 12, then only we can think about the ovarian drilling if the medical treatment fails. Thank you for your patient hearing. Dhanyavad. I thank all the organizers for giving me the opportunity to present my this talk. Thank you.
Thank you very much, Dr. Varsha Vaste, madam. It was an in-depth review of all the insulin sensitizers, and you have very well explained the role of insulin sensitizers in PCOS. Today we are having an endemic of diabetes and metabolic syndrome, and we are facing a lot of patients of obesity, PCOD, and metabolic syndrome. So the first lecture, Dr. Prerna has explained the role of HbA1c, that is glycosylated hemoglobin. So I want to combine the two lectures so that we should do HbA1c for all the infertile patients and PCOD patients, and preconceptionally we should do HbA1c, and those who are having higher HbA1c, we should offer them insulin sensitizers so that it will be helpful for better outcome. You explained that almost 80% of the PCOS patient and 95% of obese patients are having insulin resistance. So there is a very good role of insulin sensitizers in our practice, and we should liberally use these insulin sensitizers in PCOS and obese patients to improve the maternal and neonatal outcome. Thank you.
Thank you very much, sir, and Dr. Varsha Vaste, madam. We have nearly 700 viewers logged in today, and they're waiting to listen to our final speaker. And we are privileged to have Dr. Amay Purandare with us. Sir has just finished his Foxy meeting and joined us today. Thank you so much for joining us, sir. You have already been formally introduced. Requesting to introduce the next speaker, Dr. Saurabh Dani.
Thank you, Pratik. Thank you, Pardesi sir. Thank you, Dr. Sagar Kataria, Dr. Varsha Vaste, Dr. Prerna, to be a part of this AMOX webinar. Indeed, it was very informative, as I gather from Dr. Sagar Kataria's summing up, and what I could hear Dr. Varsha Vaste talk when I was able to hear the last part of it. Apologies to Dr. Pratik Tambe that I could not be there from the beginning, as I had to attend an important Foxy meeting. as we move on to the next talk, the last one for today, it gives me great pleasure to introduce Dr. Saurabh Dani. Dr. Saurabh Dani is a consultant OBGYN at the Ankur Namaha Cloud9 hospitals in suburban Mumbai. Dr. Dani has special interest in high-risk pregnancy and newborn screening. Just like APJ Abdul Kalam was called as the missile man of India, Dr. Saurabh Dani is called as the newborn screening man of OBGYN. Dr. Saurabh has been the Vice President of the Indian Society of Prenatal Diagnosis and Therapy. He has been Treasurer of the Mumbai Nursing Home Association and past President of the AFG, that is the Association of Fellow Gynecologists of Mumbai. He is also the Scientific Secretary of the Kandivli Medical Association and the Coordinator for the Mumbai Municipality Newborn Screening Program. For me, it is a great pleasure to introduce Saurabh because Saurabh and me have been roommates during our residency at Wadia Hospital. And indeed, it is a proud moment for me that Saurabh has taken with great passion this topic of newborn screening, which is essential in optimizing the future generations of our population. Over to you, Saurabh.
So please unmute.
Yeah. Thanks, Amaya, for comparing me with another one, the great past president of India. Let's not talk about foxy presidents, but jumping right away to the president of India, that's a huge leap. So before I'll just start sharing my presentation. Okay. Fine. So as we go ahead with the talk, before I begin, let me just thank Nandita, Arun Nayak, Pratik Tambe for inviting me for this MOGS conference on endocrinology. Thank you, Chairperson Dr. Pardeshi and Dr. Kataria for being here, and hope I am going to learn something from your vast experience after the end of this talk. And the two excellent and beautiful talks given by my previous speakers, that is Prerna and Dr. Varsha Baste. So relatively compared to my previous speakers, my job is much easier. I don't have to worry a lot because all at the end of the day, what we are just looking at is how newborn screening is so important as far as the babies are concerned. And before we start, let me just say that all the efforts which Prerna would have put in for pre-counseling and Dr. Varsha Vaste would have put in to see that a PCO baby mother conceives and becomes pregnant would be all futile if we just wouldn't be able to give a very good healthy baby to the parents. And one screening really comes up into going to be for today is going to be very simple. Okay? I have to just convince all the people who are present here listening to me that yes, it is very important to do newborn screening. It is very easy to do newborn screening, and I have to just show the right way of doing it. So if I achieve, when I talk about this, the three important points, I done job which I am supposed to do and I'm expecting. What basically is newborn screening? So is it a test? Is it something that you will look at and then decide? Whom will you advise it? When is this test done? How is this test done? And what should be done? Okay. So newborn screening is not a test. It's a program. So it's a screening program wherein you don't pick and choose whom you want to do the test on, but you decide what the population is on which you are going to do the test. And once you is whatever the target population is, then you just start on doing the newborn screening test on everybody. So here, what is the target population? The target population is every newborn or every baby which is born or every baby which is live born is the target population. So here we are not going to pick and choose on which parent or which babies we are going to do the test. So the second point is, yes, if this has to be done on all the babies, who is going to advise it? It is going to be the obstetrician or the pediatrician or the neonatologist. It is in. I will just show you in a slides that who is supposed to do it. But in one simple answer, the answer is according to me, the role of a neonatologist or pediatrician is very limited as far as newborn screening is concerned. It could be more relevant when you diagnose something later beyond when you do a test. How is it done? When is it done? That we will take care in the next few slides. So if you look at documentation and what has been advocacy across by all the associations, National Neonatal Forum has way back in 2010 already proposed in its evidence-based clinical practice guidelines that newborn screening should be done for all babies who are born in India, in each and every corner and nook and corner of India. According to them, all the babies should be screened for a basic panel. And if you are in a risk resource setting, you should be screening for more than the basic panel. So that's how they have defined. Now, the question is, why should we screen really? Okay. And who should be talking about it? So, if you look at these guidelines which are coming from NHS and ACOG, they are very clearly telling that by 28 to 32 weeks is the time when we have to talk about newborn screening to the parents. And the only person who is going to be in touch with the parents at that point of time is none other than the obstetrician. So there is no chance that anybody else is going to talk about newborn screening or introduce the concept of newborn screening, but the obstetrician. Now, these are the two countries where newborn screening is mandated. Okay, so in US, there is a law which has been passed which mandates newborn screening to be done in all the states. And in UK, it is part of the NHS program. So even when in these two countries where it is mandated, it is still expected that the obstetrician or the pregnancy caregiver talk about newborn screening and educate about it. So there is definitely in a country like ours, it is none other than the obstetricians who have to take the burden of the counseling and talking about what is newborn screening. So in 2021, the government of India has come out with a national policy for rare diseases. And under this policy, what is it talking about? It's dividing the all the rare diseases into three major groups. The group 1, group 2 and group 3. So group 1 is where there is a one-time treatment which is available. Group 2, which is a long-term treatment, relatively lower cost. And group 3, where there is a definitive treatment available, but the cost of treatment is very high. Maybe you could have just read recent maybe some WhatsApp forward also that injection was 1.5 crores through crowdfunding, of course, and then that was given for SMA. So this is how the new policy, and this new policy is all the rare diseases. So when we talk about newborn screening, we are not talking about doing rare diseases, but it's a group of collective disorders. So when you collectively look at all these disorders, they are not rare. Individually, they could be rare. So what is the current scenario as far as newborn screening is concerned? We have newborn screening programs in Chandigarh, Lucknow, Jaipur, Maharashtra. Lots of states have a newborn screening program, and a lot of smaller cities and districts are doing a newborn screening program. So let me share something where I have been actively involved. That is the MCGM newborn screening program. This program started as a public-private partnership in 2019, and the whole idea of this program was to screen all the babies who are born in the 4 major Medicaid, that is 2 years still now. Already more than 24,000 babies have been screened, and in this period, we have detected almost everything. So the whole idea of the screening program is to screen that is congenital hypothyroidism and hemoglobin variants. So Dr. Prerna just pointed out that in Northeast, in Assam, they find a lot of hemoglobin E disorders. And she would be surprised that in Mumbai also, in all the newborns, the incidence of hemoglobinopathies was pretty high. It was almost 1 in 100 or less than, much more than 1 in 100 also. The detection time that is the time to confirm a certain disorder from the time of birth was less than 7 days, which is a very ideal time. Need to start the treatment as early as possible. So the incidence is almost 1 in 2,000 for congenital hypothyroidism, 1 in 5,500 or 1 in 6,000 for congenital adrenal hyperplasia, and almost 1 in 200 for G6PD. Mind you, this is in compared to other parts of India. Mumbai is a very heterogeneous population. It has people from all walks of life, all geographical areas, and people belong to all surnames. Then this is the kind of data that we get, and definitely this data will change depending on different geographical locations where you start a newborn screening program. So point is that should we be doing newborn screening at all? So as an obstetrician, what are the things that we commonly do in newborn as far as screening is concerned? We do screening for Down syndrome. Incidence is almost 1 in 820. We do screening for syphilis, that is a very rare test. The incidence is 1 in 1,000. Thalassemia screening, that is almost the incidence is 1 in 800. And if you look at the incidence of almost in the range of 1:900 in some parts of India to almost 1 in 2,000, what we have seen in Mumbai. So the incidence is there, it's common. It's just that we are not doing it till now. And we need to think about making this as a routine part of antenatal and newborn screening. So let me look at what should be done as far as newborn screening when we decide that we want to do a newborn screening test. We have different options of tests that can be done. So the master panel, or the biggest thing that, or the superset of everything, is the RUSP. That is the Recommended Universal Screening Panel. Okay, so this is shortlisted on the basis of several information and data which has been collated over years by the health administrators in the USA, and wherein it is a master list of all the tests which should be included. So what they do is that they see what is the prevalence of a certain disease, whether it has a differential diagnosis, whether it is a differential diagnosis to any other more commoner problem, what is the treatment options available, how easy is it to treat, is it acceptable, do we have a confirmatory test available. So based on all these criteria, it is decided whether certain disease should be included in the newborn screening panel or. So yeah, I have shared the link. You can just go on the link if you want to learn more about the RUS guidelines and the RUS criteria. Then what is the NNF, that is National Neonatal Forum of India, talking about? That all babies should be screened for CH, congenital hypothyroidism, congenital adrenal hyperplasia, G6PD, and OA, that is hearing screening. So what is Maharashtra government doing? Maharashtra government has started screening in districts of Maharashtra. It's still not completely covered, wherein it is screening all the babies for congenital hypothyroidism and congenital adrenal hyperplasia. And what is the Mumbai Corporation doing is all the 4 medical colleges, they are screening for congenital hypothyroidism, congenital adrenal hyperplasia, G6PD, the sickle cell disease, and hemoglobinopathies. So this is the kind of spectrum of different newborn screening or public healthcare program that we are doing. Now the question is it easy? If you, it's just a matter of you deciding this, I want to start newborn screening, and you don't need anybody else to do it. This is a test which is done after 24 hours of birth. So this is the time when the baby is still in the hospital. It is not discharged. Normally we discharge the babies after 48 to 72 hours. So this is the time which is before the baby is discharged. So just before the baby is getting discharged, you collect the blood sample. So how is the blood sample collected? It is collected on a special on this CLA should be used, what information should be there on the paper, what all should be done so that we minimize errors. Okay, and if you have the right filter paper and the right technique of doing it, then you are guaranteed to get the right results. So how is this test done? So if you look at the filter paper, it has a barcode, it has a unique ID, it has the expiry date, it has the circles which are there. So that is what is talking about the filter paper. Then it will also tell you about what are the kind of lancets to use, so that if we do not injure the baby in the process of collecting the blood. So the blood is collected by a heel prick. So to prick this, we need a lancet. The lancet is details are given by WHO. So how much depth it should be, what is the kind of thickness it should be having. So that is the right use of light lancet, so that you get the adequate amount of blood for do the right processing. Then on the fourth box, what you can see is pulse oximetry test, wherein we are just putting a pulse oximeter and trying to see the difference in between the right arm and the right foot. And this way we can find out if there is a baby suffering from critical congenital heart disease. And then in the last box, what I am showing is the OAE test. It is a very simple test where a earphone is put into the baby's ear, and the machine transmits certain sounds, and on the basis of that, the machine detects whether the baby has any mild, moderate, or severe hearing deficiency or not. Now, all these tests should be done as early as possible. So the blood test is what is something. So there are three parts of it: the blood test, the hearing test, and the pulse oximetry test. So the blood test is done before the baby is discharged. The hearing test has to be done within the first month. And again, the pulse oximeter test has to be done within the first 48 to 72 hours. So, show you exactly how a newborn screening test is. You need a spirit, a lancet, an envelope where you're going to put in the right collected filter paper. To clean the side of the baby's foot, the area which we need to prick will just be shown. So this is the area that you prick. It is not on the heel, but on the sides of the heel, either the left or the right side. You allow a big drop of blood to be formed. Once a big drop of blood is formed, okay, then what you gently just apply the filter paper on it, and the filter paper will completely absorb the blood, and it will be seen on both the sides. So we are just waiting for the big drop to form. Okay, so now this is adequate enough. Yeah, this is a good spot. Apply the filter paper, okay, and you can see, yeah, see a good blood is formed. So same way it can be done the other way. You can allow it to, with gravity, you can allow it to fall, and just put it and pack it and send it across to the newborn screening lab. So these are the 2 years which I am talking about. 2003 is the year when I started my practice. So I finished my post-graduation at Vardia Maternity, and I immediately started my practice soon in 2003. And 2008 is the year when I started newborn screening in my practice. So it's been almost 13 years. And I would like to take this opportunity to share what I've done in these 13 years and how I've faced the challenges and how I've overcome, and today how we have been able to perform universal screening at my own setup. So it is a very simple thing to start. First, we have to decide at which panel we want to do. So the way I look at it is something which is basic, which is being practiced around by the public healthcare authorities in your area, and depending on the kind of affordability your parents have. So in our area, what we have done is we follow what is the MCGM guidelines. Plus we add because we can like Mumbai. So here what we are doing is we do congenital hypothyroidism, congenital adrenal hyperplasia, G6PD, which is as per the MCGM guidelines, hemoglobinopathies, and we can add galactosemia or biotinidase to this and just do this test. So how do you counsel about it? So simplest way to counsel is do group counseling. It's going to be very difficult when you do one-on-one counseling, because then you will have to talk to everybody and spend a lot of time in counseling, because this is something new where even the parents are not heard of about it a lot. So group counseling works because that is other issues related to pregnancy. And when it is a group, everybody has queries and everybody tries to understand. And this saves your time also. Then the most common question which is asked is, it is costly. I don't think that it is costly. It is how you perceive the cost. Have you ever thought of what is the cost a parent or the whole society undergoes when we have a mentally retarded child in a home? Because if congenital hypothyroidism is undetected, then we delay the treatment by around 3 weeks or 4 weeks, then we are losing almost 5 IQ points every week, and these babies are going to suffer, and so would the families along with it. And definitely it is so the cost is not a big factor, especially when you look at the kind of money which is spent behind the mobile phones and cars and education and so many other things in life. What would it really be worth it if we cannot give a good healthy baby or a good future to the baby? Then the question comes is that, okay, it's a test for the baby, so why should I decide and let my pediatrician decide what they want to do? We have to realize that though the test is done after the baby is born, but the information to be provided is much before. So almost at around 28 weeks of pregnancy or little after that. So when we are giving this information earlier, it might as well be just carry on and get the test done, because there is no rocket science involved to do this test. It's a very simple way. All the staff can be trained into doing this test, and it can totally work on autopilot without the doctor really getting involved in this newborn screening program. Once you decide that you want to start the newborn screening program, all you have to do is just tell them, the patients, that yes, we do this newborn screening in our hospital and it's going to be offered even to your child. In case if you don't want to do it, you let us know and we will not do it. Okay, so that's and don't leave things like this on the patient. Don't tell them, can you choose whether you want to do it or not. It's always better when you tell them that it's important, it has to be done. But if you don't want to do it, you can choose to opt out. So opt out is a better thing to do than an opt in. So what is the right way? If you do decide to do newborn screening from tomorrow, I think the first thing that you will, as a beginner, you will have or you will want to know is choosing the right lab. So how do you choose a right lab? It's not very easy to choose the right lab. If you really try to understand, you have to see whether they are performing any quality assurance programs or something or not, which is managed by the CDC. Then what is the proficiency test results? What is their false positive and the false negative ratios? Whether they are accredited with NAPL or any other accreditations are there or not. So it's little difficult and complicated. But then how can we make it simpler? We choose whatever is available best in the country. Okay. So when you're a beginner, it's always important to start with the best. As you become more and more advanced or experienced, then you can now choose, okay, you can try to compare other things also. Look at the experience, what the lab has. How old is the lab? What is their experience in performing newborn screening? It may be a very big lab doing a lot of other tests, but their experience in newborn screening may not be much. So it is better to choose somebody with more experience in the kind of test that you want to do, rather than just seeing the history of the laboratory. How soon are the reports going to be? Are reports going to come within 3 days, 4 days, 5 days, 7 days, 10 days? Because the more the delay the reports come, the more time we are wasting in managing or treating or diagnosing. How easy is it reporting? So I think Prerna was saying earlier, that when you try to interpret the TOG, if you can't interpret TOG properly, it's better not to get it done. Yeah? So here also it is the same way. If you get a very complicated report with a lot of values and you can't understand and you can't know what is right and what is wrong, it will unnecessarily complicate things. A newborn screening report has to be a very simple report. It should just tell you whether is it normal, or if there is a problem, what is the next step that needs to be done. It doesn't need to have a lot of medical jargon inside, something which even a relative can understand. And the last thing I would put is the cost. See, cost differences between different labs would hardly be around 10-15%, not more than that. But at the trying to go initially in your practice, what you may find is that you may not be able to really define whether it's false positive or false negative, because when you are looking at incidence of maybe 1 in 100 or 1 in 1,000, you may not, it may be almost several years, before you really come to know whether a certain lab is really up to its mark or not. So don't look at cost as a very important factor when you're starting a newborn screening program. If once you have a lot of experience behind you, and then you can start choosing, if you can get an equal or a better quality at a cheaper price or not. But with the kind of healthcare costs which are all around us, and the kind of non-healthcare costs also which are behind a child, I think the cost of newborn screening is hardly negligible. So that's all about newborn screening. It's simple. It's very easy to do. If you have any questions or anything, maybe now, maybe later, you can always get in touch with me, and we can take it. I will stop my presentation.
Thank you, Dr. Saurabh, for being so precise and so correct about this particular aspect of newborn screening. I think it is going to be a standard of care in every newborn birth. And I think that as OBGYNs, we must take it just as we take the responsibility of ensuring that the first cry or the first sign of life is the OBGYN's responsibility. Before we hand over the baby to the neonatologist, we must counsel our patients, explain to them why we are doing this, because these small steps will help in improvement of not just the neonatal outcome, but even the future adult outcome of these newborn babies. So thank you so much. You have already driven this particular project in the Mumbai Municipal Corporation. I think it's an example for other Amoxians to learn, so that at their appropriate district and local level, they can get in touch with the authorities and make this particular project not a dream, but a reality. So thank you so much, Saurabh.
Thank you.
Fantastic talks by all the three speakers. I'd like to express my gratitude to all our chairpersons. And if there are any closing remarks, please. 700 viewers are still logged in. There are no relevant questions from the audience as of now. In case we have any in the next couple of minutes, we will them to the speakers. I would request Dr. Pardeshi sir and Dr. Sagar Kataria to let us know what is the status of newborn screening in your particular zones. Is anybody actually doing it?
Yes, sir. Actually, Dr. Saurabh has really enlightened about newborn screening. And in our area also, we are particularly doing newborn screening from starting, means from conception to up to delivery also. In fact, we have done more protocols regarding to start from the dual markers, then triple markers, and when to do sonography and all that. And even just like the first talk of Dr. Prerna, so we will be doing as far as possible. It's not like that Metro Mumbai people are coming for preconception counseling and care, but still we are trying to do them these services and do HB electrophoresis, because sickle cell and all those, they are very much common in our area adjacent to Andhra and all those. And even diabetes is now prevalent in like cities like Aurangabad, Latur, Nanded, Parbhani and all that. So preconception also giving, and as far as possible. But in Mumbai, they are having advantage of doing all even invasive tests and all those. But we are quite lacking these facilities, but we are trying. And but the advantage of ultrasound, so it's quite easy for us to do so. Many things they are very easy. And now the MTP law, they extended up to more than 20 weeks. So it's also useful for diagnosing at least. But screening is very important, as Dr. Saurabh told. Next talk, Dr. Varsha Baste has really explained about the sensitizer, insulin sensitizers. These are very important, and she has cleared the ideas when to give and how to give, and in which places, unnecessary use of all, and how to use with BMI and all that. She has explained very nicely. Thank you so much. All speakers are very nice. Prerna has explained very nicely in stipulated time. Actually, preconception counseling is a really very important part. Like Saurabh Dani also, that screening also has important, because nowadays, if screening will be more, then again I am telling repeatedly that maternal morbidity and mortality is also less. Then the prevention of NTDs and all the birth defects, like genetic defects, that will be less. And many, not only morbidity, but psychological stress is also reduced in these cases. Thank you so much. All three speakers were really excellent. And thank you, Dr. Pratik, for organizing such a nice webinar.
Yes, I
Thank you,
think Dr.
Dr.
Varsha Baste wants to speak something. Yes, ma'am, please go.
Can I, Dr. Sagar? See, Dr. Dani, it was really excellent presentation, and it tells your sincerity to bring in the best of the knowledge and giving the best of the service to the society. Being an infertility specialist, we are nowadays, everybody is doing double marker, triple marker. We are not doing much of it, but double marker, we believe in it. But we are doing NIPT for 46 chromosomes nowadays, because all the patients are high-risk patients, and we do not want, everybody wants a baby without any problem. So the 100% confirmation chahiye, not only the screening nahi chahiye, we want the diagnosis. So we do generally do, and though it is little costly, depending upon the patient selection, if the patient can afford, because it costs almost 18,000, 20,000, but they are really relieved of getting it done in NIPT of 46 chromosomes, and that is what we are doing. Previously, we used to do for 5-6 chromosomes, but now we are doing it for all chromosomes because it is available now. Thank you.
Ma'am, just a comment here, ma'am, Varsha ma'am. Are you doing NIPT for a specific period of gestation, or you're doing it throughout?
Yeah, 11 weeks. Exactly. That is a very good question. You see, 35%, more than 35% of fetal cells should be detected. Otherwise, the report may come negative, even if you send the blood. So exactly around 11 weeks, not before that, not after that. 11 weeks is the precise timing to send the blood.
Because these labs, because as per Dr. Dani has suggested, choose the right lab, because whenever we suggest
a very good lab, otherwise
anytime you can do.
We have tried before 2-3 labs, but now we are standardized with one lab that I like LifeCell. It's really good. They're very quick in reporting, giving good result and appropriate result, and very efficient. So I'm really happy with their results and also service.
We have our zonal coordinator, Dr. Kataria, sir. I would request him to give us.
I would like to add one thing that about cost of this neonatal screening. See, we are spending too much for diagnosing Down syndromes and trisomy 18-21. We are providing first trimester scan. We are doing double marker. In that aspect, the cost of neonatal screening is not that much. So only problem is general public awareness, and what we should focus on is general public awareness about the neonatal screening, because once it is accepted through the society, then everyone, it will be a talk of mouth and everyone will be accepting the neonatal. What is happening right now is we have to spend much of the time to counsel the patient to do the test. So this counseling part should be reduced. So the general public awareness is very important in that aspect.
And Dr.
Saurabh wants to respond.
Dr. Pratik, just I wish to add in this, our Aurangabad OBGYN Society, they are doing combined program of thalassemia, sickle cell anemia, and that with association with the Aurangabad Thalassemia Society, and they are giving the HPLC and all other tests in just 25% rates, so that the screening will be easy, management will be easy, and we are doing
HB
programs with
electrophoresis. Sorry, HB electrophoresis hardly costs 800 rupees. So we do
Madam,
it as a screening test for each and every.
Madam, that is correct. But still, in rural areas, in taluka place of Marathwada, it is not possible. Even if you want to ask Prerna, even in Assam also, it's quite difficult,
Yes,
right?
very
Right, Prerna?
difficult.
Exactly,
Very difficult,
exactly.
sir. That is why I asked ma'am about the NIPT, because whenever we send the NIPT to a lab, they never say no.
Exactly.
Even if we are sending it at 18 weeks, they never say no, because they get it very less. Once the patient goes to the lab, they return it after the cost is just explained to them. So it's very difficult to get it done here.
I think Amey wants to speak. Amey, please go ahead.
2 points I want to make. One, about in continuance of what Dr. Baste said. See, it is essential, absolutely essential, that if we are using NIPT as an important diagnostic test, because the rest of the markers are mere screening tests. So if we are going to use NIPT as a diagnostic test, we should ensure that you have the best lab evaluating the sample. You cannot compromise on that. It may be a little expensive, but you should have a standardized lab where you know that the best of quality control is there, and standardized assessment of Indian samples has been carried out, because each lab has got certain mandatory regulations for them to start rolling a test to the general public. Point number 2 that I want to make in response to what Dr. Pardesi said, sir made a very important point about lowering the cost of the test for thalassemia. If we want to make universal screening for thalassemia actually possible in Maharashtra, we must ensure that the cost is minimal. Any screening test is applied to the general population. It is not for a selective population. If the very fact that it is called as a screening test, it is for the general population. And if you want to apply for a general population, cost should not come in your way. Otherwise, the test is of no value. So we must ensure that we emphasize to our patients, to the NGOs, to the labs, to the government, to our colleagues, that we need to ensure and motivate everybody to bring the cost of thalassemia screening down. Last but not the least, just like immunization, just like blood grouping and typing is an essential part of neonatal care, so also neonatal screening, at least the basic tools that Dr. Saurabh talked about, okay, those should be done, because we will be able to pick up things much quicker, much earlier, rather than be in a conjecture ki why the baby is not doing well or why the baby is not growing well, etc. So there we say that yes, immunization is a part of care, breastfeeding is a part of care. Similarly, newborn screening should be a part of care.
Yes.
Because
Thank you, Dr. Amey.
it is not a invasive test. It is a non-invasive test. It is done routinely to get blood group or to get bilirubin. We are pricking the baby. So that's why this is also done with a minor knee prick or heel prick rather, what Dr. Saurabh showed in his video.
Saurabh, you wanted to say something before you were interrupted. Please go ahead.
Yeah, what I was saying is that, we put a lot of emphasis on the cost factor every time. So we always say cost has to be coming down, cost has to be coming down. Not realizing that by not doing it and keeping zero cost, the amount of cost which is passed on to the family or to the state government or the central government is huge, because we are not realizing this. Let me give a very simple example. If we just delay maybe
6PD.
looking at a population or incidence of 1 in 2, because thyroid is 1 in 2,000. If we have delayed this diagnosis for maybe 1 month or 2 months, in a population of Mumbai, which is having a birth rate of more than around 10,000 babies who are born every month, we would be getting 5 babies who are going to be with congenital hypothyroidism, and eventually they would have low IQ because they would have not been immediately diagnosed. So over a year you would have almost around 50 to 60 babies who are mentally retarded, which are all reversible. So for this, now what you have to have a special schools, you need special teachers, then you need to have the parents have to spend a lot of money. So because you wanted something very cheap, you are not talking about it and not doing it, but the cost which causes to the whole society whole is huge, which we just don't understand. Program in most of the countries wherever it has been implemented. See, in a country like India, we have three structures of healthcare. We have the public healthcare, which is under the state government. Then we have the private healthcare as corporates, and then we have a smaller healthcare system as nursing homes. See, nothing, neither vaccines or immunization in private setup is totally a call of the doctor. So if you think you want to do it, you have to just start it from tomorrow. You don't need to wait for the government to come and tell you, okay, please do it from tomorrow. It is only the public healthcare where the decisions have to be made. So like the way we impressed in Mumbai, that this was very important and it should be started. Today, I can tell you that more number of people in the lower socioeconomic status are being screened in Mumbai than in the higher socioeconomic status, because we don't still see 100% newborn screening happening in the private sector, but definitely all the babies who are born in 4 medical colleges are being screened. So we, even as a private setup, now the government is not going to fund this. And as far as the cost is concerned, what is the cost of a public healthcare program is very low. Means I will say, when you're talking about 800 rupees for just screening for thalassemia, here in Mumbai, within less than 1,000 rupees, we are screening for all these 4 disorders. So there is no question about cost being so high. It will go down as the number of tests go up. But today you cannot wait for the cost to go down and then say that I will do the test. You have to start doing it first.
Excellent reasoning. Anybody else would like to comment before I present the final vote of thanks? Yes, sir,
I wish
please.
to add Dr. Pratik in this, but the good thing is that awareness will be increasing. Means 2 patients, means they were from software engineers and they were in IT and all Google. They said one in their family was with SMD and one was with having breast cancer. So doctor said, what to do? So it was really right question. So I told them, see, now SMD is quite a costly, even with BRCA also. But now gene sequencing and gene editing will be there. So I will refer to Varsha Baste or Mumbai for them. But still that will come. Now definitely that will come also, and that will reduce cost also. No doubt its cost is very high. Technology, we know all India, but technology we are lacking. But that will be coming and awareness will be increasing. Thank you so much.
I would like to just, if there is a little time, I would like to add in 1-2
Yes,
sentences.
one final comment. Yes.
Yeah. See, nutrition is very, very important. If you want to avoid, all gynecologists, we as a clinician should know nutritional values and what is the benefit of giving good nutrition, macro, everything we should know in detail. Like little bit, I will tell you, hyperhomocystinemia is responsible for so many problems. And if conversion of homocysteine to methionine done by vitamin B6, B12, it is very, very important. So we should know when to use it, how to use it, and why is it needed. So even this methylene, the tetrahydrofolate reductase enzyme deficiency will cause the simple folic acid conversion to tetrahydrofolate hampered, and so this unmetabolized folic acid unnecessary is not utilized. And people are giving preconception in folic acid. We have to use that tetrahydrofolate. Now it is abundantly available in the market, so why not to use it? So clinicians must educate themselves to utilize nutritional supplements. They should know the values and they should put some time to know and educate themselves. If we give good treatment, everything can be solvable. That is what my thing, because PCO is after all, it is NCDs are after all what? These are all metabolic syndromes because of the deficiencies. We have to correct them. So that is what I feel. So.
One point I want to make, Saurav Dani sir, that you have suggested that the obstetrician has to go for the neonatal screening. But what I just want to add on here is that it's good that we obstetrician tell the patients that, okay, your baby needs a neonatal screening, but it is always necessary that the pediatrician reinforces it to the client, because once we have been seeing the client for 9 months, they will question us that we have done all the necessary tests till the NIPT as you have suggested during our antenatal period. Now why this neonatal screening again? So the pediatrician has to reinforce this particular thing, and then it will be better.
Are we running short of time? Then
Yeah, we are. I think this was addressed by you during your talk when you said that the
correct.
focus has to be on an opt out rather than an opt in. And once that focus changes, all our problems of counseling and direction will probably be solved. Correct me if I'm wrong.
Pratik, I just want to make a point. I agree with Prerna that as obstetricians, like Dr. Pardesi said, it is our job to build health awareness, to educate the pregnant lady and her family about neonatal screening, to ensure that she is looked after in the antenatal period in the best of health, like Dr. Baste said, giving way importance to nutrition, etc. To deliver her safely, ensure that the baby is handed over to a neonatologist who, in addition to clinical screening, to ensure that the baby is crying well, feeding well, vitally stable, that's the time when the intervention of neonatal screening comes in. So the onus of executing that or implementing that is with the neonatologist or pediatrician, because the consequence of that is going to be tackled or managed by the neonatologist and the pediatrician. Our role is very important to ensure, like Saurabh said, that we counsel them properly, explaining why this is required and how it is important in the long run. But to implement it, we are not the implementers, I strongly believe. It is our friends, the neonatologists or the pediatricians, who will take charge. As they take charge of the baby and the baby's various issues in neonatal period and then infantile period, similarly, it is their onus and responsibility to take this fact. This is my honest opinion.
Amaya, they will be more than happy to do that. But if you have counseled them first.
Yeah. No, I said
Absolutely.
I said that it is our responsibility to counsel because the patient is with us for 9 months, even before 9 months, like Dr. Baste said. So our counseling should begin from that time in a phasic manner, slowly informing them of all the information and then handing over the baby to the neonatologist who implements or executes this.
Correct. Yeah. So
I don't think that the obstetrician should get into the interpretation.
No, they should not. And this is what is called as teamwork, that we as a team, obstetrician as a team, talk about it, neonatologist as a team executes the thing. And that's how we get a wonderful product.
Thank you everybody for that wonderful discussion at the end. I'd just like to present the vote of thanks at the end of today's program as the convener. My gratitude to our AMOX President, Dr. Nandita Palchetkar, Secretary, Dr. Arun Nayak. Thank you so much for the continued blessings for our CME series. Today's program was themed around key issues in obstetrics and gynecology. We had 3 fantastic stalwarts as chairpersons, Dr. Rajendra Singh Pardeshi sir, our Vice President of AMOX, Dr. Sagar Kataria, our Zonal Coordinator, Dr. Amya Purandare, State Coordinator and Vice President-elect. 3 amazing speakers, Dr. Prerna Keshan, who is the Youth Coordinator for C. The amazing talk and insights from Dr. Varsha Baste on the role of insulin sensitizers were much appreciated. Thank you so much for being here, ma'am. And finally, Dr. Saurabh Dani's eye-opener talk on newborn screening, something which we can all take back home. And we can start implementing it from tomorrow morning itself in our daily clinical practice, because that is how we can make a change. Each of these talks has given us a lot of thought and practical take-home messages for daily practice. We hope they are of use. The 700 plus delegates who are logged in. I'd also like to express my gratitude to ICOG Chairperson, Dr. Mandakini Meg, Secretary, Dr. Parag Beniwale for the ICOG credit point. The Science Integra backend team, Subbu Session, thank you so much for being there. And finally, last but not least, the Acumentis Viviana team, who are our education partners. Thank you for being with us through this entire series of events. We hope to see all of you very soon, the next event. Until then, goodbye, God bless, take care and stay safe. Bye for now.
Thank you for the opportunity. Thank you. Bye.